All right, welcome. So now is your time to ask questions from our great speakers. I hope you guys are having a great time. I know that to start, we do have a question from our live streaming event. So I'm going to start with them first. So just give me a second. We do have 2 microphones in the room. So I'll have one on this side of the room. And then Dr. Farias Omar, he's going to have a microphone as well for that side of the room. But we're going to start with our online viewers right now.
So the question from the live stream was for Dr. Restrepo, and the question was about any connection between atopy and hormonal disorders such as hyperadrenocorticism.
That's a fabulous question. Absolutely, and you notice because of, well, I would say in the interest of time, I didn't address that during this lecture, but absolutely, not every itchy dog has allergies. And so secondary pyodermas as a result of hyperadrenocorticism will cause secondary infections that can make dogs itchy. So absolutely, if I use our history and clinical lesions, so when I have a dog that mainly has truncal rashes that later itch, so that's why we use the term the rashes that itch versus the itch that rashes, like with allergies. So with hormonal conditions, typically I'm finding truncal rashes. You have an older age of onset of these rashes. So the dog that's never had skin problems, now it's 7 years old, all of a sudden it keeps getting recurrent pyodermas on its trunk, and obviously steroids aren't working or something like that. And so those are the dogs that I clue into looking for Cushing syndrome or hyperadrenocorticism. So excellent question.
All right. Anyone else? All right, we've got one. No, I'll get you next.
How do you deal with the dog? Is it on?
It wasn't.
Okay. How do you deal with the dog that reacts to the immunotherapy, like right away at the beginning?
I guess I'll try and tackle this first. So the question really is, how do we deal with dogs that react to those initial injections? We look at it, or oral. We look at it a couple of different ways. The first thing we look at is diluting out and even starting even lower than what we were. That's kind of where we go first. And those patients who react to the injections, we'll go the sublingual route and see if we get less reactions that way. The other thing we'll do with the sublingual is maybe try to go once a day rather than twice a day. So we're just trying to find a lower frequency or a lower dilution that allows us to get started and see if we can't work through some of those issues.
And then also sometimes I'll actually have them bring in their patient for the first couple of injections so that I can monitor them, because sometimes there is a little bit of factor of intimidation by the owner, and sometimes they see things that don't actually exist. So really having that patient come in, you administer the injection, you watch them the entire day, and maybe you do that for 3 or 4 injections in a row to see if you can repeat what they're seeing at home.
Okay, I know I've got one right here.
There is regional variation in atopic dermatitis. I'd be interested to hear from each of the panel members, what is the average number of things in the environment that a dog is allergic to? For example, in Minnesota, I might tell an owner that on average a dog will react to between 5 and 10 different things in the environment. However, there's regional variation.
I suppose I'll start. My mic on? Yeah, I agree with that, and I think we see that the extremes of that is perhaps between North America and Europe, where in Europe one of the most common presentations is to have dust mite only. I think a lot of that reflects exposure. In the Midwest, where I practice, which is very close to where you practice, I'd agree with your sentiments that 5 to 10 things might be common. Having practiced in California for a period of time, I can tell you that, and I'm sure my colleagues will support that, in California and Florida, once in a while it's a few more than 5.
And I would have to agree with Doug from the standpoint, I'm also pretty regional to the Midwest, being in Iowa, is that we also see about 5 to 10, but we do see a lot of dust mite. But maybe one of the things that we think of that other people don't is we're looking at maybe corn or some of these very regional allergens that aren't really a big concern if you're in Naples, Florida, or LA. So
Yeah, absolutely. I mean, there is quite a bit of regional differences, and and I would say in Paradise or Naples. So we typically have a hard time picking just 12 or 15 allergens. So that's usually my max is 12 to 15 to place in my antigen vial, because otherwise it'll be too dilute. So, but typically that's an average.
I would have to agree with Dr. Restrepo. In LA, it's anywhere from 10 to 25 sometimes, and sometimes I have to look at cross-reactivities. But on our test, we do have a lot of things that have, like, we'll test for 3 different storage mites and 2 different dust mites, and a lot of times they're all light up in terms of that, but keeping that in mind.
So another question from the chat stream. What are you thinking about Sensitest from blood sample? And I would just generalize that to all blood and serum testing.
Ooh, we could get into a tricky situation.
Yeah.
So is the question, what do we think about serologic testing for allergies?
I think that is the question.
Okay. So maybe we can start a fight.
All the other dermatologists want to get up here. So.
I think from the standpoint of what we know from just at least what's published, is that outcome result may not differ based on those tests. I think some of us may argue that some of the tests might be a little bit better than others, but that information itself might be lacking as well too. But I'm in the camp that I don't necessarily think it's as important of what the test is you use as it is who's making the decisions, who's thinking about it, who's looking over all of that stuff, and the detail that you put into that. Kind of the background of that is when you look at the number of articles that come out about allergens and cross reactions, and that's a trove of information and a difficulty at times to kind of keep up with what's out there and trying to do the best for our patients. But from our standpoint, we don't always settle in on, hey, we made this and it's perfect. We tweak it in terms of a lot of different ways, in terms of maybe changing what's in there based on outcome of our patients.
I think that we have the benefit of doing both tests on every patient we test. We do that automatically, and part of that is simply just a kind of a resident training exercise. But and we clearly find that there are some patients that are negative on serologic testing, but very positive sometimes on skin testing. So I have come to believe, and I think the data supports that intradermal testing can be more sensitive, but I will also have to say that for the majority of patients, we see pretty good correlation, or at least our decision as to which allergens we might include would be reasonably the same whether or not we use serologic or intradermal testing. So I think one of my points is for the practitioner who may not have that skin testing available, I think they shouldn't be afraid to use a serologic test.
Yeah, that's a good point. If we're each answering, then I would agree that intradermal testing is still my gold standard, and there's a big gap and difference in making that leap that higher IgE means that you're allergic to that particular allergen. And so which you can take blood samples from normal people who are not really showing signs of allergies, and you're going to have IgE to certain things or higher IgE. So that you really do make that leap, and that's where we come in with that, trying to really establish what is the history, what's the seasonality, what time of year are you flaring, knowing the different pollens and which ones are more allergenic, which ones are cross-reacting. So that's where you get the most use out of your dermatologist, is trying to put that picture together. But like Doug says, if all you have is IgE testing, you don't have, I know there's clinicians here from Canada that don't have a dermatologist within a reasonable distance. So yes, absolutely, you're just kind of left with IgE testing, and that just would be better. But there are laboratories that are much better than others, and there are some that we absolutely stay away from. So that's when it's useful to speak to your dermatologist in the area about those kind of things.
I guess I'm the last one. I definitely prefer intradermal allergy testing if I would be given the choice. I will probably do that above all else unless the dog is unsafe for any form of sedative. So unless the dog ends up in that category, which very rarely our patients end up in that category, they're usually going to be skin tested if they're coming to my office to see me.
I'd like to pose one thing that I would guess that we can all agree on, which is that serologic testing, and for that matter intradermal testing, is not an appropriate test for diagnosing food sensitivities. Would we all agree on
Agree.
that?
Absolutely.
Absolutely. Every study that's been done in that regard shows that those tests have very, very poor specificity and sensitivity for food allergy, and therefore diet trial is the key word.
100% agree.
Yes.
All right, thank you. And I know Dr. Farias has a question from his side of the room. Oh, it's this. I have the question. Hold on.
I'd like to know if you include malassezia antigen in your skin test, and if you do you consider it relevant? Do you include it in your immunotherapy?
Go ahead.
We do include it on our skin tests, and I do include it for those dogs that I do think actually have recurrent yeast dermatitis. And I have had actually a lot of successes where I've actually added it in after the fact, so that they were on immunotherapy prior, they were still breaking out with yeast dermatitis, and then I added it in. And those subset of dogs, not all of them of course, but there was a subset of dogs that did do clinically a lot better once it was added in. So.
I would agree with that, and I probably don't want to speak for Doug, but Doug, along with Dan Morris, has done a lot of the work on that in terms of showing that malassezia hypersensitivity is a real issue and trying to correlate those positive tests to what it is. But I agree with Ali. I think it's a big issue out there, and I also include it.
Yeah, I think it's a critical thing to test for, at least in our region. It's a critical thing to test for in an intradermal test, and boy, can you get nice positives sometimes with malassezia. And I think if you don't have that available, skin testing available, and your only choice is serologic testing, you should have that in a serologic test as well. And I do agree. I think it's an important allergen for those patients, and so it should be included with immunotherapy.
We include it as well, and we also see a subset of dogs that will be positive only to malassezia antigen.
Interesting.
Do you see those as well or not?
I can't say that I've seen one that was just positive to that.
I've had several, and what I've found interesting about those is you go to look at, they have beautiful lesions where you expect to find this just large, overwhelming amount of malassezia, but very small amounts that seems to be creating maybe more of this hypersensitivity. They're reacting maybe to the presence of few, but I've had several over the course of the last several years, and they've done well on immunotherapy addressing just that problem. So.
Interesting.
One here and then.
Okay, you may or may not have an answer to this. Which oral immunotherapy company would you recommend if you're in an area where you do not have a dermatologist to send to?
So sorry, which oral?
I think the question was which company clarify the question. Which company, if we're going to use sublingual immunotherapy, what company are we going to use?
Yeah.
For the treatment.
For the treatment. I'm only aware of right now that Heska is the only one offering commercially the product that was looked at in some of the studies. I know a lot of people are looking at their own variants of it, but from my standpoint, when I've gone that route, I've stuck to the Heska variant for that purpose until we get a little bit more info in terms of what that proprietary mix really is.
So I think that in the United States and in North America, there are other companies. The ALK offers a sublingual formulation now, as does Greer. The problem we have is that we can't say anything. The answer has to be we don't know, because there is no evidence. There has never yet been a study to compare amongst manufacturers with sublingual protocols or with extract sources and so forth. So the true answer to your question is we don't know because we have no evidence.
If you use malassezia in your vaccine and you have mold vaccine and pollen vaccine, where do you put it?
What was the last? I didn't hear the last part of it.
So if we use malassezia in an allergen mixture, and if it's the situation where you're mixing, where you have a mold set and a mold vial and a pollen house dust, where do you put it? Or maybe the general question is, do you mix it in with anything or what?
I have done both. I've mixed it in if I don't have two separate vials, and if I do have two separate vials, I'll put it in the dust mite and mold vial rather than the pollen vial. But I don't think I have any evidence behind that.
Yeah. Yeah, I mean, I would say I mix it too. I rarely have two separate vials, and coming from university and private practice where we've done each one at different times, meaning separate the vials versus doing immunotherapy with them mixed, we haven't really found a clinical difference.
So more broadly speaking, I think that's one question that we really haven't answered in veterinary allergy and dermatology is it okay to mix any kind of mold, fungal or mold allergen in with pollens or dust mites? I think many people are aware that on the human side, both the European and American allergy, not regulatory bodies, but professional organizations have a standing recommendation that says you should not mix fungal extracts along with pollen extracts and some others because of the protease activity in fungal extracts. We don't have those recommendations yet in veterinary medicine. One thing I will say that we found recently that's interesting, we actually have a poster on this coming up, is we assay protease activity in many different extracts, and at least what I can say to you is in terms of total protease activity, Malassezia extract has very little. The fungal extracts have a lot, but Malassezia have comparatively little. So that made me feel better about mixing it in with pollens.
Good.
Right, thank you. We have one right over here.
How specific is your cytology for ruling out Malassezia? In other words, if you get a negative test, how strongly do you feel that it's a true negative and that you don't have to just do an empirical treatment or trial?
So, I mean, unless they've just bathed the dog right before seeing me, which I typically do ask most owners to have at least a 3 to 5 day period of no bathing before our exams, or if they're on antifungals before they see me. But barring those two scenarios, if there's yeast there, I'm typically picking it up. I don't know how you guys feel about that.
The joke I always tell, and now I probably won't be able to tell it anymore, is that if I have a patient with severely itchy, greasy, odorous skin that really looks like Malassezia dermatitis, and I do a cytology, how many yeast do I need to find in order to justify treatment trial? And so my answer to that is 1. And if I don't find one, I will find a piece of debris that looks close enough to a yeast that I will justify treating that pet. So I think, and if you think about it, it makes sense. Malassezia hypersensitivity is like flea hypersensitivity. Would you say, gosh, I only see one flea, so clearly this can't be a flea allergy problem, right? So it's likely, I think, that the degree of disease that we see with Malassezia dermatitis may more be dependent on the degree of hypersensitivity rather than the absolute number of yeast. So I love to see yeast because it justifies treatment, but if I don't see them and the clinical picture fits with Malassezia dermatitis, I treat anyway. I'd be interested in hear what my colleagues have to say about that.
I kind of agree with Doug. I mean, in terms of, I don't need much yeast there at all to treat, but I'm more in the lines, I think the question a different way of looking at it is technique, and using your microscopes properly and where to look, how to look. I'm a big fan of clear Scotch tape in terms of getting an adhesive technique, but getting it around those toes or those dogs that are biting their feet. I think one of the more commonly overlooked places from general practice is the claw bed itself. Right at those claw beds where we can see a lot of debris. That's a place I'm sampling a lot of times. So from my standpoint, I think a lot of the errors where things aren't found is maybe inappropriate sample location from the standpoint of where am I trying to pick it up or look for it.
Absolutely.
I have to agree as well. Like, I'm taking cytology from all areas that look clinically abnormal to me. So if you're only taking it for 1 or 2 areas, you may be missing some of the pathogens that are existing. So making sure that every place that has a clinical lesion, you're at least putting your little impression smear on it, even if it's all on the same slide.
All right, we've got to see one right here.
If you're using steroids for management of clinical signs while you're implementing allergen-specific immunotherapy, is there any concern that the steroid use will impact the efficacy?
This is actually a pretty good question because it's a concern that we have, and that's actually being kind of evaluated very rudimentary in terms of asthmatic patients. And there is this concern that potential early steroid use can maybe lead to the decreased efficacy of immunotherapy down the road. I think now that we have different options, I think a lot of us are employing those options and maybe moving away. But when we were, in previous years, we were really left with a patient who's extremely uncomfortable looking at immunotherapy that might take 6 months to 12 months, or speak with some other dermatologists won't discontinue it up for 18 months. We had to use something, and so it was we were caught in that place. And I think that's where some of these newer options, from our standpoint, have a lot of utility, such as Apoquel or the Caddy injection, something to buy us some of that time while we're waiting for our long-term option to kick in. But it's a question I don't know if we have a specific answer to yet, because we don't have a great plethora of information to make that judgment call on.
Yeah, I would add that clinically, I've always felt that I've been able to see immunotherapy at work by my reduction in steroids. So meaning I was able to, 6 months later, be able to reduce the use of steroids. So that to me convinced the owner and myself that, well, immunotherapy is working, because before I could only use steroids. So now, because of immunotherapy, I'm not having to. And then I would add something that, I don't know if you're comfortable sharing, but certainly just anecdotally, I worry about some of the new therapies actually interfering with immunotherapy. So I wonder if that's going to actually interfere, for example, Apoquel and things like that, with immunotherapy success and potentially blocking the effects.
I think the truthful answer is we don't know, because there's never been a single study done to assess whether or not corticosteroids, cyclosporin, antihistamines for that matter, or Apoquel interfere with allergen-specific immunotherapy. I think most clinicians' experience is that even with Apoquel or Atopica, that most clinicians continue to see what they perceive as successful immunotherapy in the face of even the new drugs. Now, whether or not that percentage is lower or higher even, we don't know.
Okay, so I have definitely time for one more question, maybe two, but I'm going to keep lunch on schedule. So I'm going to start with the first hand that I saw, and then our speakers will be here the remainder of the event. So I don't want to say corner them, but you'll have access to them.
Hi, I was just wondering, when your immunotherapy is administered appropriately for an appropriate amount of time, what percentage of your patients do you see fail to respond to it?
Fail completely or fail?
Fail completely to respond to immunotherapy.
Mine around 30% fail completely. I don't know how everyone else would say.
It depends on, too, what you call failure and what the owner's perception of failure is. I think maybe the best question is, in what percentage of patients do the owners say, it's not worth paying for this, I don't want to continue? Maybe it's helping a little bit, but it's not worth it. And I agree, that's sort of a third of patients.
But you also have to break it down for the client, because they may not be able to see the improvement. Like, I'll look in my patient history and be like, well, you've been on immunotherapy for 2 years. Before you were on immunotherapy, I was prescribing antibiotics, say, every 4 months. And now I'm prescribing every 2 years. They may not see that as a clinical benefit, but I see that as a huge benefit. That maybe it's not decreasing the itch factor, but it's helping these other things that are very important. So it's important to continue that. So you have to look a little bit outside the box, whether you rate it as success or failure. Because sometimes the idea of failure in their mind is not the same idea of failure in my mind.
Yeah, I would say I prep them at the start of before performing skin allergy testing. I give them the whole spiel on success rate and prognosis and things, and I usually say anywhere from 15 to 30% is a failure rate. But I usually like to highlight to them that 3 out of 4 dogs are going to respond well, and obviously not using the words cure, but respond. And so a smaller percentage are the ones that are going to not respond.
It seems to be one of the few things most of us are in agreement about, is that I would also agree probably about a third And that's what I preface people for. And immunotherapy is definitely not one of those things I ever push on anyone, because it's kind of something we have to understand going into it, that we may do this therapy for a year, and at the end of a year, we may have to look back and say it was of no benefit in this particular case. But the way we look at that is this is really the safest long-term option. As long as we kind of assume those risks, it really is the right decision for that patient and that owner. But it's one of those things I would never push on anyone strongly.
Okay.
Setting expectations is really important for clients. Clients can't view allergy shots or allergy drops or any treatment as magic. And setting reasonable expectations, telling them, look, this is something that has a great chance of helping a lot. It may not be perfect, but it may help, but still needs to be used in the context of, should we all four say it together? Multimodal therapy.
All right. Thank you. And then with that, I'm afraid we did run out of time. But our speakers, like I said, will be here the rest of the time that we're here.